on to our next speaker, keynote address. I would like to invite Dr. Rashmin Gandhi, the master of neurophthal in India in the present times. He has an experience in the field of neuro-ophthalmology for more than 20 years. He is a director of Axon MedTech Private Limited, managing director of Foresight Worldwide, director and consultant of Center for Sight. He has so many awards and publications, and he's very much into innovation. I have to say a few more, just one. So he's a principal investigator of the role of ocular movements as a marker for dementia. He has wide interest in new technologies in ophthalmology. He's an excellent teacher, innovator, conducts revision courses for FRCS exams since 2001. And his latest achievement award is Asia Pacific Ophthalmology Society Award in 2019 at Bangkok. And I welcome sir for this talk on nystagmus evaluation. Over to you, sir.
Thank you so much. Thank you, KSOS. Thank you, Dr. Naina, for giving me this honor. It is always a pleasure to be part of the course with Dr. Elizabeth ma'am. And also thank you and Arya for taking up the more complex subjects and doing a wonderful job with it. I'm going to talk about nystagmus evaluation. If you see a patient with nystagmus, are there any steps that you would deploy in your OPD to distinguish between nystagmus, which is because of a neurological origin, and nystagmus, which is non-neurological? So these are the effective steps that one can follow in the OPD. The first question you ask yourself when you see a patient with nystagmus is it present in primary gaze or is it absent in primary gaze? Second, you look at the movement and say whether the movements are horizontal, vertical, torsional, or mixed. The third thing is to find out whether is there any fast phase to the nystagmus. If there is a fast phase to the nystagmus, that is called a jerk nystagmus. If there is no fast phase, as Dr. Elizabeth also showed, then it's called a pendular nystagmus. And the last point, which is very important, is to see what happens to nystagmus when you ask the patient to look to the right, left, up and down. I would suggest that we have this particular step done in all patients with nystagmus, and I'll show you why that is important. So now this is a first primary gaze. See this patient in a video, you see patient looking to the right. Right now the nystagmus is absent, but when it goes right to the end of the gaze, you will find that there is this little bit of fluttering movement. This is called endpoint nystagmus. It is physiological. And how do you find out whether it's an endpoint physiological nystagmus is, you'll find, see, this is absent in primary gaze. It is brought about right at the end of the gaze, and it is generally transient. Versus this patient, and I would like you to see this is absent in primary gaze. Okay? But you can see what kind of nystagmus you will say this is. Would you say this is horizontal? Or it's more like a torsional nystagmus. But the difference here, you see that nystagmus starts much before the end of the gaze. You can see the sclera here, and nystagmus has started. So when you find a nystagmus which starts before the end of the gaze, that is called gaze-evoked nystagmus. Contrast it with the endpoint nystagmus, which is physiological. Gaze-evoked nystagmus generally is because of a problem in cerebellum or area around brainstem. Gaze-evoked nystagmus can be because of the drugs. In young patient, it can be a sign of demyelination, and older patient, it can be because of the stroke. So these are two examples. The first thing we ask ourselves, if the nystagmus is absent in primary gaze, two possibilities: endpoint nystagmus, physiological, or gaze-evoked nystagmus. Now let's see if we are able to dissect what you're seeing here. It is present in primary gaze. That was the first step. Now what do you think? How the eyes are going? Any idea? Yes. So that's a vertical movement. Now, did you find any fast phase here? Look at carefully and see whether a vertical movement, is there a fast phase? Yes, the fast phase is towards a down. So this is an example of a downbeating nystagmus. So first important point, it was present in primary gaze and it was vertical. When you have this kind of nystagmus which is vertical with a downbeating nystagmus, and which is becoming much more when the patient looks down, it is likely to be again a problem with cerebellum, and as Dr. Elizabeth mentioned, it should be neuroimaged. What about here? Is it vertical or horizontal? Vertical. And now here, any difference? It has a fast phase, but it is upbeating nystagmus. Very good. Now see what happens here. Patient is converging. And the patient looks straight. What happened when the patient converged? There was a dampening. This is a classical, near classical feature of Wernicke's encephalopathy, where patient has a upbeating nystagmus. When you ask the patient to converge, either it gets dampened or it becomes a downbeating nystagmus. So we looked at two important points, whether it's present or absent in primary gaze. Second, whether it's horizontal or vertical. We saw two examples of a vertical nystagmus. So upbeat nystagmus can be because of lesion in cerebellum or lower brainstem, while downbeat can be because of drugs like lithium or lesion in middle cerebellum. Let's continue and see if we are able to see here. I know it's a little dark, but what do you think is happening? Is it vertical or horizontal? It's vertical, right? But this vertical is because of this, and example was shown. What do you think here? You can see there is no fast phase. It is swinging like a pendulum. So a difference between a pendular nystagmus and a jerk nystagmus is that in a pendular nystagmus, in a primary gaze, it swings like a pendulum. The importance of noting this down is because a lot of this, and as Dr. Elizabeth mentioned, this patient also, the pendular nystagmus was because of albinism causing foveal hypoplasia. A person born with a very poor vision since childhood, can be cone dystrophy, foveal hypoplasia, bilateral macular scar, can exhibit pendular nystagmus. So generally it is because of an ocular problem. However, these patients, you should look at the palate carefully, because pendular nystagmus can be part of what is called as oculopalatal tremor. Here you can see the palate. Also there is a tremor in the palate, which would be in synchronous with pendular nystagmus. And this, if there is a palatal tremor as well, then the pendular nystagmus would be part of a neurological disease. Now, when do you say that it is? So this is present in primary gaze. It's a horizontal nystagmus. And you see, when the patient looks to the right, what is being exhibited here is that when patient looks to the right, nystagmus almost settles down, telling you that there is a null point. Whenever you see a null point, you know that most probably you are dealing with infantile or congenital nystagmus. And as Dr. Elizabeth mentioned, that can be treated. You bring the null point to the primary position, and patient would have no nystagmus in primary gaze and would have improvement in visual acuity. So infantile or a congenital nystagmus, these are the features. They are asymptomatic. Patient would not have a symptom of oscillopsia. They are, most of the time, they are jerk nystagmus. You will have a fast phase, and mainly it will be horizontal with presence of null point, and when you ask the patient to converge, the nystagmus would be dampened. Now this is the patient many years ago which I saw in Shankar Netralaya, and one of the reasons why I got interested in neuro-ophthalmology was because of this patient. This patient actually came to our resident training clinic, where patient was diagnosed as having a unilateral nystagmus because of amblyopia. A dense amblyopia can also cause a vertical nystagmus, and patient was actually undergoing patching for a long period of time. As I said, an important step of a nystagmus is to see what happens to nystagmus when you ask the patient to look to the right, left, up and down. And I told you this is because of this patient. He was told that he has a nystagmus. You can see there is a vertical, this is called Harman-Belcharsky phenomena, where there is a vertical movement in one eye. And patient was undergoing patching for the right eye for 5-6 months. But see what happens when you ask the patient to look to the right, left, up and down. You see now there is a nystagmus in the other eye as well. Can you see there is a nystagmus in the other eye? And the nystagmus was what is described as a seesaw nystagmus. So that was missed in the initial period. So patient went around with that nystagmus for 6 months. Seesaw nystagmus is a feature of problem around optic chiasm. So we requested this patient to undergo MRI scan. Patient was found to have a large craniopharyngioma, and unfortunately he did not survive the surgery. So now we don't know if we had picked up craniopharyngioma 6 months prior to the presentation, whether the patient would have survived, but it highlights the importance of the point which was mentioned, that nystagmus can be the first and the only sign of a very serious underlying neuroophthalmic problem. This was shown by Dr. Naina. This is an example of convergence retraction nystagmus, where you see also patient has a light near dissociation, a larger pupil, and when the patient is looking at the Oken drum, there is that retraction. This is a part of Perinaut syndrome or dorsal midbrain syndrome. So these are the nystagmus which has an effect of convergence. That is the last step of your examination of nystagmus. Congenital nystagmus typically would be dampened by convergence, and an upbeat nystagmus may become better or may become downbeat, as seen in Wernicke's encephalopathy. These are the nystagmus which probably can be treated with medications, and generally that is done by a neurologist. Some of these nystagmus do respond to medications like memantine or neurontin or tegretol. Dr. Naina also wanted me to talk about ocular flutter, the square wave jerks and opsoclonus, which are part of a similar kind of problem. The square wave jerks are abnormal saccades where the eyes, they are always horizontal and they move and they come back, they move and they come back. They are called square wave jerks. In a horizontal way, there is no gap, but the eye just keep moving without any saccadic interval, then that's called ocular flutter. And if they keep moving in all direction, then it's called opsoclonus. The square wave jerks, which is generally transient, may be non-specific, while ocular flutter and opsoclonus would be because of neuroophthalmic problem and would require a further workup. Some of the videos that I showed you were given to me by Dr. David Z. David Z is one of the foremost authority on ocular motility and nystagmus. He works at Johns Hopkins University, and some of the patients were seen when I was working at Shankar Netralaya. I thank you once again for your very kind invite.
Thank you, Dr. Rashmin Gandhi, for the very nice presentation. You have cleared many doubts, made nystagmus so simple. I have just one question for you. What is your opinion about medical treatment like baclofen and all? And are you doing it, and what is the dose?
Yeah, so I generally ask my neurology colleagues to see whether they are, because most of the time these patients would have some underlying neurologic pathology. We have seen some of these patients saying that they felt better. I've never seen any nystagmus completely go away, but sometimes patients do report a minimal improvement in vision. Surprisingly, patient with superior oblique myokymia, which is not directly a nystagmus, I have 2 patients now who have responded to topical timolol drops, where they are symptomatic. Superior oblique myokymia, when the eye is twitching, they feel that image jump when they look at the books and all. And they said that the frequency had diminished completely with topical timolol twice a day. For after 2 weeks, they reported the change. But as I said, it's too small a number to say that it really works. But the medication, I don't have any patient who came back and said that it completely went away.
Any question for the audience? It was an exhaustive session, pre-lunch.
So when you find a case of nystagmus, when do you advise surgery? My question is then in infantile nystagmus without face turn, do you advise surgery, and what is your personal?
So we had done a observational kind of study in Shankar where we said that, oh, patient does not have a significant face turn, just a little face turn, but has a null point. So can you now just bring the null point to the center by doing a procedure and see if patient reports any change in visual acuity, since null point is where patient probably has the best vision. We didn't really find significant change unless there was a face turn. So we feel presence of face turn or a neck deformity is where the surgery would help the patient the most. And just a word about what Dr. Naina had mentioned about the saccades. We don't check saccades so often, but they are sometimes the pursuit movement, the way we check the oculomotility in our clinic might be normal, and the only abnormality can be saccadic slowing. In a lot of neurodegenerative disorders, PSP, first sign would be saccadic slowing. Parkinsonism can show saccadic slowing. If you are referred a child who has Wilson's disease, they can show saccadic slowing. Early or recovered cranial nerve palsy, like say 6 nerve palsy, can have only saccadic slowing in one eye. I mean, the ocular movement will be full.